The topic of this video is stereotactic body radiation therapy, SBRT. Those are high-dose treatments in the body of the patient outside the cranium. Now, if you haven't looked at the last video, that was about SRS. Those are high-dose treatments in the cranium typically. So you might want to go back and look at that because some of the technology and techniques are relevant for this video as well. So here we go. When SBRT was pioneered, this was the system that was used. This is the end localizer frame, similar to what we saw in the last video on SRS in the cranium, but here it's down in the body. That was used to localize the lesion in space, but it's no longer widely used. And the reason for that is that image guidance is often used to deliver it, IGRT. Here you see an example where the tumor from CT scanning is outlined in yellow and the expansion with the margin in red, and you line up the scan on the day treatment with the intended target. Here are some dose fractionation schemas for SBRT coming from different protocols in lung, liver, and spine. These are from RTOG trials, and they're fairly representative of what you'll see in the clinic. You'll see that the dose fractionation schemas are very high dose, delivered in a few fractions. So a common one in lung is 20 gray times 3 or 12 gray times 4, and in the other sites as well. If we look for a moment at how patients might be selected to receive SBRT, here are some of the criteria for mainly focusing on a lung tumor. Well circumscribed tumor sizes less than 5 to 7 centimeters, high dose per fraction. In the lung, you'll see the RTOG protocols are also, this particular one is looking at treating peripheral lung tumors. And so they define it as being outside this dotted region from the first branching of the brachial tree. If you go more immediately, more towards the center, the toxicities get higher. Now let's go back to this table and look at margins. Looking at the lung case, you'll see the protocols are advocating for an ITV with a 5 millimeter expansion beyond the ITV if the 40 CT is used. So as you'll recall from our discussion about motion management and assessment, you can measure the motion of a tumor with 4D CT. You go through the different phases of the breathing cycle and you make an ITV, and then that's expanded into a PTV, and that's what they're calling for in these protocols. All right, now let's move on and talk about the very important topic of dosimetry in SBRT, or treatment planning. SBRT plans are much more heterogeneous than plans with standard fractionation. That's by design. It's a very important concept. If you look at this, let's look at a dose profile through this treatment. It's 18 gray times 3 treatment, and you'll see it's very peaked in the middle. So here's the line and here's the dose profile. And you'll see we've got 54 gray to the 63% line, and then there's a hot spot in the middle, 85 gray at the center. And the reason it's designed like this is to provide a sharper fall off for the dose distribution. And you can do that at the expense of having a hot spot inside the tumor. This translates into the DVH, you'll see it here. So the PTV here is in green, and it has a big shoulder, and you'll see there's a hot spot that's inside the PTV. So it's not a straight line step function that you see in a homogeneous dose distribution. So SBRT plans are different. You have a very conformal dose distribution around the target. You limit the spillage of low dose, and in particular, you limit the dose to normal tissues. So SBRT plans are a little different. Their prescriptions are set differently. And here are some parameters that are drawn from some cooperative group protocols. Number one, you'll see the prescription isodose line is at a relatively low percentage, 60 to 90%. And again, that translates into a hotspot inside the PTV. The max dose should lie within the PTV. That's important. And your DVH parameters should conform to the following specifications listed here for the PTV. Let me show you what these two look like on the graphs. So here it is. You'll see that you have the volume receiving 100% of the prescription dose, and the volume receiving 90% of the prescription dose. And basically it's telling you you shouldn't have a cold spot in the PTV. Now, in addition to the PTV coverage, you also have to pay attention to the surrounding normal tissue. A key reference for this is the series of so-called high-tech papers from AAPM on hyperfractionated tissue tolerance. Here's one for the optic structures. They go by organ-specific sites. Here's the list as it stands now. In planning, of course, it will be possible to make a plan that overcovers the PTV, and it could achieve the dosimetric goals for the PTV, but it would give a large dose to the surrounding tissues. That would be unacceptable. So we do have to look at normal tissue dose, and there are some metrics that help us guide us with that. So one is the conformity index. So that is defined as the volume of a particular isodose line divided by the volume of the PTV. And then another series of metrics quantifies the spillage of low dose into normal tissue. So let's look at a couple of those. Here's intermediate dose spillage, and you can look at two different volumes here. One is the PTV expanded by 2 centimeters, and then the other volume is the 50% isodose line from the plan. So let's look at those two values. So our 50% is defined as the volume of the 50% isodose line divided by the volume of the PTV, and so you want that to be small, so it's more conformal. You can also define a quantity called D2cm. In gray, that's the maximum dose at 2 cm from the PTV. And these two quantities help you control the spillage of low dose. So the limits for these various dose metrics vary with the protocol, but some commonly used limits are conformity index less than 1.2, a lung of V 20% less than 10 gray. Some protocols allow for conformity index up to 1.5, lung V 20 up to 15 gray before it's considered a major violation. The appropriate limits for R50% and D2cm are a little bit harder to define because what is achievable depends on the size of the PTV. Here's an illustration of that from one protocol. Here you see the PTV volume on the left going from small to large, and you'll see the R50% should be less than 5.9 for a small PTV, but as you go up in PTV size, the R50 needs to be smaller in order to satisfy the protocol. Similarly, there's a dependence of the max dose at 2 cm from the PTV. It might be 50% for a small PTV, but it could go up higher for a larger PTV. So here's an example. Let's say that the prescription is given as 18 gray times 3. Here's the volume of the PTV. Here's the volume of the prescription isodose line. And here's the volume of the 50% line. Here's the maximum dose at 2 cm. And the question is this plan acceptable? So have a look at this and see if you can figure it out. Okay, now let's look at planning techniques. So here you'll see 3 different plan types: VMAT, a non-coplanar IMRT, where the beams come out in different planes, and then coplanar IMRT, where they're all in one plane. And there are several features that you can appreciate here that are common to these. First of all, these are more conformal, but there is more dose spillage out into healthy lung. You'll see that the cloud here is spilling out more, but at the expense of conformality and the speed of treatment. Clinically, however, this is a relatively small effect. Here are the DVHs from these 3 plans for lung tissue, and it's kind of hard to appreciate the differences. So it's unclear that you can say any one is better than the other. All right, now we come to the technical recommendations around SBRT and how to do it safely, and I'm drawing from a couple different reports here. The Task Group 101 report from APM is a definitive resource on this topic. First of all, you need volumetric imaging for alignment. The reports say this now, and you should not use the body frame alone to accomplish SBRT. Second, there are some requirements about on the technical dosimetry end of it. So the dose calculation grid size should be small. you should use a low energy beam. The MLC leaves should be at least 5 millimeters or less, but if you go less than that, there's little advantage actually. You should conduct an end-to-end test. That means irradiating a phantom as if it were a patient, all the way from simulation to treatment planning to treatment, and then exposure of some type of test object inside that phantom. There should be some way of assessing for motion in the thorax and abdomen. And then some requirements on treatment: a physicist being present at the first fraction and available nearby for remaining fractions, and the radiation oncologist to approve alignment images prior to each fraction. And those have obvious workflow implications, especially in certain clinical arrangements. All right, hopefully that was a useful overview of SBRT. It's an important topic, widely available now. Most clinics in North America and Europe offer this technology for patients now, so you need to know about it. I'm going to leave you with a little bit of further reading. This is somewhat an evolving topic, so these references may be useful. And I will see you in the next video. Thank you. So I hope you found this useful as an introduction to SRS and SBRT. Here's some more reading materials that you can delve into. Unfortunately, in the standard textbooks, such as Kahn or McDermott, you won't find a whole lot of material on these topics, but there are other resources out there. Thank you.